Hi, my name is Nick Makins, and I'm going to be talking today about medical choices in which the decision maker is uncertain about their patient's preferences. Although I'm sad not to be able to be in Dallas for the VMST conference in person, I'm really glad to have the chance to share some of my work via this online symposium. So I just want to thank the organisers for putting this together and thank you for watching this video. Okay, so healthcare professionals have to make choices for their patients on a daily basis, and many of these choices have to be made while some matter that's pertinent to the choice is not yet settled. That's to say, these choices have to be made under uncertainty. Often this is uncertainty about the outcomes that will result from the available options. Will this treatment work, for example? Will the patient recover without any intervention? That sort of thing. Sometimes, however, there's a form of evaluative uncertainty instead. What I mean by this is uncertainty not about what outcomes will arise from which options, but instead about how good or bad these possible outcomes would be if they were to occur. Now, there are various different forms of evaluative uncertainty, but the form that I want to focus on here today, and that comes up a lot in medicine, is uncertainty about the preferences or values of a patient on behalf of whom a choice is being made. Now, there are a whole host of contexts in which medical professionals will need to make choices that really ought to depend on what their patient values or what their patient wants, but in which they don't know what those patients' preferences are for one reason or another. I mean, it's not hard to think of examples of this, but just to get things going, I'll offer a couple. One type of example would be an individual who comes into the emergency department unconscious, perhaps having been in a road traffic accident. And because of that, they're unable to state what their preferences are. But a load of choices about their care and treatment are going to need to be made. And in particular, these decisions are sort of urgent. They need to be made now, and we can't wait to find out more about the patient's sort of particular wishes and desires, their particular values. So in that case, some choice is going to have to be made while the decision makers might be uncertain about the particular preferences of that individual. Another sort of example would be instances in which an individual is detained under mental health legislation due to a severe mental health disorder, quite possibly lacking capacity to make some particular decisions for themselves. Now, they might well have advanced directives or something like lasting power of attorney, but they might not. Or those mechanisms just might not provide enough information for these choices to be made on their behalf in a way that's fully informed by their preferences. Now, what I want to argue today is that one of the standard ways of dealing with outcome uncertainty can also be fruitful for making these choices under uncertainty about patient values. Now, there's actually a huge literature out there concerning these sorts of cases. Well, actually several different literatures coming at it from different perspectives. Some talking about consent, some talking about the rights of the individual and the responsibilities of the clinician, capacity, best interests. And sort of all of these different perspectives, I think, provide something useful to the discussion. And what I say here isn't really supposed to contradict or even really compete with these ideas. I see them all as providing useful conceptual tools to evaluate and make decisions. Today I just want to focus on one way that we might think about these choices that I think sort of perhaps hasn't been fully appreciated. Now, a lot of the attention that's been paid to these sort of difficult choices concerns or is focused on finding out what the patient's preferences are. So, for example, clinicians are encouraged or perhaps even legally required to speak to the next of kin or to consider previous choices that a patient may have made, consult any advanced decisions that they have. And they need to do all of this before making a decision on behalf of a patient. I take it that the aim here is to resolve the uncertainty, to establish the facts about what this patient might prefer. And that's really important. Like, I don't want to argue that or sort of diminish the importance of really trying to find out what a patient wants. But I just think it's important to note that sometimes these choices are going to have to be made while the uncertainty persists. Despite our best efforts to find out what somebody wants, sometimes decisions are urgent, or sometimes it's just very hard to find out exactly what their preferences would be. And so it's important to think about how we might do this. The way I want to approach this problem is to think about sort of several different approaches that one might adopt that are reflected to varying degrees in the literature, and in fact also in the law and in practice. So the first such approach is something like nothing about me without me. The idea that healthcare professionals should do nothing without the explicit consent or active involvement in the choice of a patient. Now, I mean, this principle has something going for it in that it emphasizes kind of the empowerment of patients to be involved in shared decision making. And I think it's right that where possible, patients should be really richly involved in the decisions that affect their care. But I think for a couple of reasons, this principle isn't at all the right way to go. It might sort of be somewhat obvious, even just from the way I've stated it so far, that this isn't going to get us all the way there. I mean, for one thing, it implies that healthcare professionals ought to do nothing even when there's urgent need for treatment, so long as the patient isn't able to actively consent or be involved in choosing that decision. I mean, it just seems clear that there are plenty of choices that should be made on behalf of the patient, choices that we would all want to be made for us, even if it can't be made on the basis of the sort of active involvement of the patient. But secondly, withholding treatment is itself a choice. I mean, if we opt not to provide a treatment because a patient can't actively consent to it, we're still making a choice on their behalf that doesn't involve them. So, I mean, it's not even clear that this would be a coherent view or possible to implement. Okay, so we're going to have to look for something better than this. It's not a great start. An alternative would be that doctors and other healthcare professionals should act in accordance with the patient's preferences when these are known, such as when the patient is able to express their preferences themselves, or when there is a valid and applicable advance directive or advance decision, or I don't know, where there's other kinds of really decisive evidence to establish what exactly it is that a patient would want. But that when this isn't available, when we don't know what a patient wants, we should sort of fall back on some alternative, perhaps objectively defined goal. Something like promoting health or preserving life. I actually think something like this has increasingly become the sort of standard view in the law, where, I mean, in the US and the UK, for example, when a patient can state their preferences directly, or when they have an applicable advance decision in place, then doctors have to follow what they say. But as soon as there's substantial uncertainty about a patient's preferences, when we sort of don't have these really decisive bits of information, then they move to a best interests framework instead. And this best interest framework is often quite different from simply following whatever it is the patient says they want. I mean, it's worth noting that some guidelines on best interest assessments do make space for patients' preferences to play an important role in deciding what's in their best interests. And I mean, there's this rich philosophical tradition linking well-being and preference satisfaction. But even then, there is some objective notion of well-being that ultimately takes precedence. In the Code of Practice for the Mental Capacity Act in the UK, for example, it states that any assessment of the best interest of a patient should consider the past and current wishes and preferences of that patient, but that the final decision has to be based entirely on what's in that person's best interests. Okay, so this approach, I think, has more going for it than the first approach. At least some of the time you can make choices that are guided by a patient's preferences, even when they're not able to explicitly consent to the treatment concerned. If you have decisive evidence about what they would want, then you're able to proceed. The problem with this approach, I think, is that it throws the baby out with the bathwater. I mean, clearly there are loads of cases in which we have some reasonably good information about what a patient would want, but that falls short of certainty or knowledge. And in these cases, I don't think we should just disregard the information that we do have simply because it isn't enough for knowledge. It isn't really clear why some uncertainty about patient values kind of downgrades the importance of acting in accordance with them in the way that the Mental Capacity Act, for example, suggests that it should. Okay, so perhaps a third approach which might improve on this further would be to say that we ought to act on the balance of probabilities about what a patient prefers. So we should do that which we think is most likely to be what the patient wants. Sorry, my slides have just frozen for a second. Okay, yeah, so this balance of probabilities approach, I think it sounds intuitively pretty good. If you don't know what a patient wants, then do what they probably want. It's quite hard to disagree with that. And assuming that you're fairly diligent in forming beliefs about what a patient might want, then this is going to get it right in a lot of cases. It also means, unlike in the first two approaches, that decision makers will be able to ground the decision in the interests of the patient by their own lights, even when one is uncertain about what they might want. So So this means that we can have these choices based on the values and preferences of the patient in just many more cases than in either of the previous two approaches. So it looks fairly good for this third approach, but I actually don't think this is the right account either. And to see why, I think it'll be helpful to consider why a similar approach isn't adopted under outcome uncertainty. And this will also show why I support a fourth alternative instead. Okay, so to see why this sort of approach isn't the right way to go for outcome uncertainty, it'll be helpful to think of an example. So here it is. Here's the sort of decision problem that we're facing. So the decision maker has a patient, and they are uncertain whether this patient has examplitis, which is more likely, or caseopathy, which is possible but less likely. And they have to decide what treatment to give. There are three options, A, B, and C. Treatment A is highly effective against examplitis, but ineffective against caseopathy, where being highly effective is a complete cure, and being ineffective is going to result in the patient's death. Treatment B is the other way around. And treatment C sort of gives you a somewhat guaranteed outcome of being moderately effective no matter what, no matter which of these two diseases the patient has. Now, just like in choices under uncertainty about patient preferences, I think there are two parts of the response to this kind of decision under uncertainty. Firstly, we should aim to reduce the uncertainty by just gaining more information. Run some tests, gather more information from the patient, and so on. But we're also going to need to think about how to make this choice while the uncertainty persists, particularly if it's an urgent choice. And in this case, I think it seems intuitively clear that treatment C is the best option. I mean, it doesn't guarantee the absolute best outcome, but it does guarantee that we avoid the absolute worst outcome. And in fact, I think this sort of thing, this sort of approach, or choosing this sort of option is fairly standard in clinical practice. When choosing antibiotics for infections, for example, it's quite routine to start with a broad spectrum antibiotic, which might not be the most effective against the specific organism, but it'll cover all the bases until you get results back from the lab, and then at which point you can move to a more specific treatment that's going to be more effective for the specific organism that is causing the infection. Now, one way of capturing what's going on here is that although treatment C isn't in fact going to be the most effective option, treatment C is the option that has the highest expected value. So if we were to attach some numbers to represent the probabilities of the diagnoses and the values of the states, as I've done in the decision table now. So examplitis, rather than just being more likely, we now say it has a probability of 0.7 and caseopathy a probability of 0.3. And we attach some numbers to represent the value of the possible outcomes as well. I mean, I've just sort of plucked these out of thin air, but we can think of them as something like health utilities. Then we can calculate the expected value of the various options. And when we do this, we get the answer that seemed intuitively right in the first place. The option that has the highest expected value is treatment C. This treatment which will be moderately effective no matter what, but isn't going to get us either the best or the worst outcome. In some sense, in this case, it looks like we should hedge our bets or something like that. I want to point out a couple of things about the judgment in this case that'll be instructive when coming to think about choices under uncertainty about patient preferences. The first is that despite treatment C being the one that it seems we should pick, it's not the one that's most likely to be the most effective. So the most likely state of affairs here is that this patient has examplitis. And if that's the case, then the most effective treatment is going to be treatment A. In fact, stronger than this, we can be certain that treatment C won't be the most effective treatment, whatever disease the patient has. I mean, either they have examplitis, in which case treatment A is going to be the most effective, or they have caseopathy, in which treatment B is going to be the most effective. So no matter what they have, C isn't going to be the most effective treatment. But nonetheless, we quite rightly opt for that option here. One other thing to notice here is that we get this result because expected value is not only sensitive to the likelihood of the different states of the world, nor only to the best possible outcome, or the outcome in the likeliest state of the world. It's sort of sensitive to all of these things. So it's sensitive to the value of the possible outcomes as well as their probability, and the value not only of the most likely option. If we were going only on the likelihood of the best option, then we'd end up with a different choice, and I think we'd all agree that would seem like the wrong one. And it seems really important here to think about not only how likely the various options are, the various states of the world are rather, but how good or how bad the outcomes would be, whether or not they're the most likely ones to come about. Now, this idea actually isn't really groundbreaking or new. In fact, this is precisely the way that many people think good reasoners should and in fact do go about making choices under uncertainty. And there's plenty of literature arguing for exactly this sort of thing, or applying this sort of method to medical decision making under this kind of outcome uncertainty, as you can see by all the references that are covering my slide. But I think that something similar is actually going to be the right way to think about choices under uncertainty about patient values. So my claim is that when choices about a patient's care have to be made under uncertainty about their preferences or values, healthcare professionals should aim to maximize expected value. And crucially, this means not always choosing the option that's considered most likely to be the one that the patient concerned would want. So this is rejecting the balance of probabilities view that I presented. Now to see how this might work, I want to consider an example. So let's suppose there is a patient who is unconscious and has lost a lot of blood. It's clinically decided that they need an urgent blood transfusion, but they cannot consent to this or express their preferences about it. In fact, there are some family members present, some of whom are adamant that this particular patient wouldn't want the blood transfusion, even if that might lead them to die because of their religious convictions. There are other family members present, however, who say that they would want the transfusion. They don't have any advanced decision in place, and they've never had to make a decision like this before. So the decision maker might well be uncertain about whether or not this patient would prefer to have the blood transfusion or not. And in fact, they might think that there's a roughly 50-50 split between these two different sort of possibilities in light of the available evidence from this patient's family members. Let's also suppose in this case that this uncertainty just can't be resolved within the time frame of the choice. Something is going to have to be done one way or the other before we're going to be able to find out and really settle the matter of what the patient wants. Now, in this sort of case, I think it seems as though it would be worse to withhold the transfusion from a patient who would want to have it than it would be to give the transfusion to a patient that wouldn't want to have it. And this means, given the equal likelihood of the two possibilities, that giving the transfusion would be the option that has the higher expected value, and is therefore the option that should be chosen. Now, this isn't the option that's more likely to be what the patient would prefer. By stipulation, I've already said that it's roughly 50-50 between whether they would prefer to have it or not, given what we know. But that doesn't mean that we're now just making a best interests decision, or that it's just a tie between these two options. This choice can still be based on the decision maker's beliefs about the preferences that the patient has, even though these are uncertain. Or take another possible example. Suppose that during a surgical procedure, there's an incidental finding of some condition that could be treated there and then while the patient is under anesthetic. But the surgeon is uncertain about whether or not this is what the patient would want, given the risks involved in this further procedure. Now, the surgeon might judge it to be in the best interests of the patient to go ahead and treat. They might even think that this is what the patient is most likely to want, but it still wouldn't be the right thing to just proceed, to go ahead and continue this surgical treatment, because of how bad it would be to do so if that particular patient didn't want the treatment. Now that possibility isn't captured by an evaluation of the best interests of the patient, nor is it captured by thinking about what they're most likely to want. But it still seems to be a really important consideration that we don't actually go ahead with this sort of treatment in this sort of context. And that's something that reasoning along the lines of expected value can capture. The key point here that I want to emphasize is that when we don't know what a patient wants, we shouldn't just do what we think is in their best interests, nor should we simply do that which we take to be most likely to be what they would want. But rather we should balance the likelihood of what they might want with how good or bad the options would be in the sort of under these different possibilities. And this is basically what expected value gives us. I want to sort of offer one final comment before wrapping things up. And this is to note that expected value theory sort of comes with some technical baggage. We have these numerical representations of likelihood and value. And it might seem as though this is something of an unrealistic way to go about clinical decision making. But I want to note in sort of response to this that on at least one popular interpretation of expected value theory, it isn't necessarily a procedure to be followed literally, but rather a theory that describes some of the structural features that good decision making can have. It can be a way of thinking about and evaluating these choices without requiring that decision makers actually assign probabilities and values in this way and calculate some numerical measure in order to guide their decisions. Okay, so in conclusion, I've argued that when making medical choices under uncertainty about a patient's preferences, healthcare professionals ought to maximize expected value. Sort of illustrated this in a couple of cases. And that's the end of my talk. So thanks very much for listening.